I'm Sigrid Carlsson, and I'm an assistant attending epidemiologist at Memorial Sloan Kettering Cancer Center in New York. So to provide you with a little bit of summary on this session on update on prostate cancer screening in 2021. So we heard from stakeholders and professors from all over the world, and they all claim to have the answer to how to solve the screening equation. What they all had in common was that they all propose a risk-adapted strategy to prostate cancer screening. And we heard various combinations of risk adaptation. A lot of them incorporate the use of MRI as a screening tool in addition to the PSA test, so before biopsy. There was also incorporation of risk calculators and reflex tests such as the 4K score and the SOCOM3 test, and also use of genetics. One study suggested to start early screening at age 45, and then we had one study that proposed to use only MRI instead of the PSA test. And I think all these studies show very promising results in keeping the benefits and reducing the harms of screening, so mainly reducing overdiagnosis, but keeping the mortality reduction. But a lot of the studies are still ongoing, so we'll wait another 5 to 10 years before we have the final outcomes. So more on that to come in the future, but I think it's a major leap forward in prostate cancer screening. Yes, so that's a really good question. I think what we mean by maintaining the benefits of screening is that we know from the previous randomized trials, or the ERSPC, PLCO, the Göteborg trial, that the PSA test is a very good screening test for prostate cancer. So those trials showed that PSA testing can reduce prostate cancer mortality with follow-up. So we want to maintain that benefit, but then of course we want to reduce the harms, so overdiagnosis and overtreatment. And so that is the hope, that with these new screening strategies, we can at least keep the mortality reduction, but then reduce the harms. So, but it is possible, of course, that we can increase those benefits, so we can still, preserve the mortality reduction, but also increase benefits in terms of reducing overdiagnosis and reducing other types of harms and anxiety and other important aspects of screening. That's also a really good question, because I think a lot of these strategies hold a lot of promise. I think they're all very creative and innovative and promising strategies for keeping the benefits and reducing the harms. So I can't say that I can pick one winner of these now, because like you said, we have to balance the effectiveness of these trials and the trial results with the costs and the resources, and it really depends on the setting where these screening strategies will need to be implemented. So it depends on what resources you have, and is it feasible, and will patients accept these types of screening tests, and can you scale it on a large scale, and so on. So it's hard to determine today if we have the full equation figured out yet in terms of sort of the cost effectiveness of this whole package, if you so will. This is also an excellent question about contamination, because that was a problem in some of the prior studies where you had so much contamination in the control group of the trials that it reduced the statistical power to detect a difference between the two arms. So in these studies, the ongoing studies, they have now been designed so that you take contamination into account when you do your power and sample size calculations. So as you noticed in this session, a lot of these trials are very large. So 50,000, 60,000. So they have to be really large scale trials to be able to really show a difference in between the trial arms in terms of the primary endpoint. And the other important thing is that a lot of the times the control group is usual care. So whatever is usual care, if it's PSA testing or whatever is available, is the comparison arm. So it's really not that no arm, don't get any screening at all, but you compare usual care to whatever your intervention is. Well, this is the million-dollar question. I think one of the talks here in this session was a call to action for a 2027 implementation of screening in Europe. But I think it really depends also on, again, what country and what the resources and the public health policies are, and the settings where you are. So, for example, in Sweden, a man's lifetime risk of dying from prostate cancer is very high. So it would make sense, to have some sort of organized program, or evaluating the organized testing in one way to sort of establish a program in countries where the risk is high and where you have maybe resources and depending on other healthcare needs in that setting. So I don't think there is a one-size-fits-all answer that all countries in Europe should have a population-based screening program in the future, but it might be that there are strategies and opportunities that could be discussed on a Europe-wide level.